everybody, and welcome to the PT on ICE Daily Show. My name is Christina Prevett. I am one of our lead faculty in our pelvic health division. And today I wanted to talk to you all a little bit about vulnerability in obstetrical care. If you have been kind of seeing my stuff online lately, you know that I've been talking a lot about kind of having some of these healthcare reframes. And I love a good reframe. But one of the things that I asked, and I asked this related to aging, but I want to bring this into obstetrical care as well, is when we are thinking about how our older adults are treated. Our older adults, they're coming into our healthcare system feeling sick, feeling vulnerable, feeling like they don't have that much resiliency, and feeling like a lot of decisions and independence are being taken away from them. And one of the things that I ask at our older adult courses is if you reflect on how people are treated, our older adults are treated in healthcare, would you like to be treated that way? And I got some great responses about that kind of topic. And I think it's really relevant in obstetrical care too. If I am teaching any of our pelvic health courses, I will tell you all that I have never felt more vulnerable within my own body than around labor, delivery, and in particular, the first, several months postpartum. And so the question that I have to ask is, when you kind of think about the stories, your own obstetrical journey, potentially if you're somebody who's given birth, or the way that your patients are telling you or talking to you, would you like to be treated that way? And one of the things that brought this up to me, I have not been as open on this platform, but I have been very open on my personal Instagram that I felt very vulnerable postpartum, but I am starting to feel very vulnerable again as a want to be mother of 3 who is currently going through a miscarriage. And so I've been really open about my journey of fetal loss. I had a suspected chemical pregnancy that ended up being a subchorionic hematoma that led to bleeding at 7.5 weeks with my third child. But what I have not been as open about is a little bit more about some of the downstream consequences of that miscarriage, and that my bleeding was in the early part of November. It is the end of February, and I am still in obstetrical care and management for that fetal loss. So what my primary care doc, who is incredible, did was they mapped my beta HCG to make sure that it was coming down. I always get a little bit tripped up talking about this. So if I get emotional, I apologize. But at the beginning of February, I hadn't had a beta done and it had stalled. So I was still at 88 for my beta HCG, and it was supposed to come down to 0. And so now we're past this almost 12-week window. And my doctor was starting to become concerned about retained product. Got an emergency OB consult. I was being seen with my primary care doc for now. Had an emergency OB consult. They were kind of going through different options with me. This was late last week. And one of the things with retained products that they have to make sure that they rule out is a molar pregnancy. And a molar pregnancy could be something that could lead to a specific type of cancer. And so usually the management for that retained product is not to allow a medical or using a medication to get that tissue out. It's to have a D&C. And what brought this I'm kind of getting to my point here. What brought this front of mind was my OB. This was a resident that was talking to me. She was very, very kind. And I said, okay, well, what can I expect for a D&C? And she said, it's a surgical procedure and it's a day surgery, and we'll put you under, and then, you'll have to fast and all this kind of stuff. And she was very clinical about it, right? Which I appreciate. I needed to get the facts. But all I kept thinking to myself is that I'm going to be unconscious, my legs are going to be spread, and I don't know how many people are going to be in the room, and I'm going to have a very wanted pregnancy scraped out of the side of my uterus. And when you think about that, it feels very cold. And I said to her, I was like, I know that this is she knew that I was a pregnancy researcher. And I was like, I know that this is the procedure, but like, gosh, this feels horrible. And she was trying to make me feel better. And she's like, we do these every single day. Because she worked in the pregnancy loss clinic. And I actually like when I stepped back, I thought, that's fantastic, right? From a safety profile perspective. But that was not what made me feel better. That didn't make me feel better in that moment. And I know that I'm gonna have like probably some therapy I'm gonna have to do on the other side of this DNC, which I'm still waiting for. And so, what I started to think about was the vulnerability of individuals in obstetrical care and some of the trends that we've started to see within the OB space. And one of the things that we've seen, which I think is fantastic, is having more support for mom being advocated for at the time of labor and delivery. And that's usually in the a space and sphere of doula care, right? And so doulas are there to be mom's advocate and to help them feel supported from a personal, like mental health, like and physical health too, but like there for the heart and soul of the mother when there is something that is medical that is going on. And we have very good level evidence for the support personnel being there. Though we have some issues in doula care, like there isn't any type of standardized education and things like that. But that's a whole other discussion. But what the other thing that I was thinking about, and I kind of thought about this in all realms of healthcare because I was asking this about older adults, is what about our healthcare system is how are we I'm trying to get the wording right because I'm still like noodling on this is when things start to go wrong in obstetrical management, that is where so many of my patients and myself, I'm currently experiencing this myself. This is where individuals start to feel like they are just another body and and it feels very cold. And I'm not saying that this is all providers. I'm not saying that our obstetricians are feeling this way. And but it can feel very like that there's like an ick factor. I definitely have like I know that I have to go get a DNC. I know that this is the procedure and it's going to keep me safe and it's going to try and be the thing that's going to preserve my fertility. But I can definitely see how there is this coldness that comes into medical procedures and how it's necessary that we have this coldness because we want to make sure that we're clear and that our physicians are developing this pathway where they have proficiency in their jobs. But when things go wrong, I can also see how this perceived coldness, whether it's true or not, because my resident was not cold at all, but the procedure feels very cold. Why this may also be creating this negative voice within obstetrical care that I am seeing right now, where there is this very big push away from obstetrical management towards like midwifery care, which is incredible, to home births, to this visceral reaction to medicine. I'm not really saying about those individuals who are more drawn towards that holistic care. It's the negativity that's placed on the option of obstetrical care that I'm seeing a lot in discourse online. And I really truly believe, and this is kind of more of a podcast about my thought experiments, is we have every right to be critical of our healthcare system, right? I am critical of some of the stuff that's happening in Canada. I'm sure you all are critical of some of the stuff that's happening in the United States. But I don't think it's helpful for us to be just spewing all this negativity without trying to think what would need to happen in order for this to feel better. And I think that in the obstetrical space, this vulnerability, this fact that, when things are going wrong, you're scared, you're stressed, you're in a cold surgical suite if you're having a cesarean, that's an emergency. Your doctors are highly stressed out, more people are coming into the room, you're literally your legs are open and you're in this vulnerable position and now all of these people are putting stuff on you. Like it kind of is this perfect storm for having this stress and trauma response. And we are starting to see that in the literature, right? Where there's a lot of individuals when interventions start to heighten that there is a big stress response that could be mimicking or is equivalent to a PTSD or post traumatic stress. And so when I am thinking about this to kind of bring this full circle, I was thinking a lot over the weekend about what would need to happen for us to feel better as patients in our offices. And then how can I turn that into a message that is one of hope and empowerment to try and make things better rather than focusing on the fact that there is a lot of negative language happening around our healthcare system. And I asked this around our older adults, and I think it's going to be really relevant here too. And I think the first thing is for us as medical providers, and you may not be an OB, but if you're a pelvic floor PT or a pelvic floor OT or a physical therapist, is when you are thinking about your patients, are you using patient first language, right? And that is going to put personhood at the center of our healthcare system. And I think this has to happen across all of our settings. So for example, I'll ask individuals about patients and they say, I have 2 total hips and a total knee, or I have a 34-week weaker, or I have a 6-week postpartum. And it's not, I have a person who has had a total knee replacement. And we truncate that language in order to speed up the way that we're communicating, but the what we truncate is the person at the center of our care. And that's number one is like, how are we focusing on patient first and recognizing too, like, and I see this in rehab all the time is we see people in pain day in and day out. And it's very easy in medicine and in rehab for us to be desensitized to that. Like a person who has heaviness, a person who has pain with intercourse, a person who has leaking or is early postpartum, like their world is rocked and everything is changing around them. And for you, it's your fourth client of the day if a person who's in that first 3 months postpartum. And so it can be very easy for us to become desensitized. And that sensitivity is important because if you don't have any boundaries, it can also burn you out. But I think reflecting on like your use of language and just having these ideas around person first language and the way that you are feeling mentally before you are going into a patient's room can be a really immediate switch of just acknowledging the vulnerability of coming to rehab in general, but especially of being in the pelvic space. And I'm talking about pregnancy postpartum, but this is so true of my menopausal patients as well. Like those who are going through menopause, their world is being rocked too, and they feel like they don't know their body, and having that space to hold for them. And so many of our rehab clinicians do this too, but I think it's important in medicine for us to be thinking about this. And so when I'm thinking about that and that personhood, what really kind of brings this also front of mind is how does this come into our education? And I know in physical therapy rehab, like so much of it is focusing on like the anatomy of the person and the ligaments and the assessment and all these types of things. And in our medical spaces, it's probably even worse where we our person is draped, like you don't even really see their faces. And that's to give a certain amount of, precision, but it can easily come into bedside manner where you feel like your provider is being very cold or calculated. And so in our education, I think it's really important for us to be thinking about or being critical of in all medical disciplines is how do we keep this patient first? And even like I'm thinking about like interview processes in our client or in our like education spaces around having that ideology around, being that caretaker. And I don't know if I'm right about any of this either. It's more like things that I've been thinking about how to help individuals who are feeling very vulnerable. And then finally to acknowledge that, there was a lot of people posting under my older adult post about how staffing makes it very difficult for you not to feel like you're just going from one person to another and it's just one body to another. And acknowledging that there's some really critical reform that is necessary from a medical space for individuals to not have this trauma response when they're in very vulnerable spaces, which is in our hospital networks, especially when things go wrong. And so finally, I want to kind of pull this around full circle and think about one, like your own interactions with your patients and checking in on your own mental headspaces going into your day today. But also to think about how can rehab unburden, and this in pelvic health, I think is so relevant, is how do we unburden understaffed and burnt out spaces to allow that personhood to come into care? And if I'm thinking about where to instead of just complain, to bring this forward into something that is helpful, is how do we advocate as a profession to unburden? And a lot of that for me has been talking to our docs and saying, hey, like, this doesn't have to be something that you bring up. I think it's important for you to bring that person to me. And I'm trying to get in with our obstetricians to talk about exercise and pregnancy because I think it's really important for us to be advocating for our role in those spaces. And in order, what I truly think, and you all, I would love to start a discussion about this, is that until we truly dismantle this hierarchy of care and acknowledge the multidisciplinary need within our healthcare system, we're always going to have bottlenecks, rushing, burnout that is going to lead to a lot of individuals feeling like another knee and not a person within care, especially when things start to go wrong. And so, I didn't think this was going to be 16 and a half minutes, but obviously I talked a lot. But I just want to know what you all thought about that around acknowledging the vulnerability of being in obstetrical care, seeing kind of for your own journeys, if that is something that is relevant to you, or in your patients, if you're working in pelvic health, how that vulnerability, especially when things go wrong, can be interpreted as coldness. And that coldness can lead to stress, anxiety, and trauma responses in our pregnant postpartum, our individuals that are experiencing fetal loss like I am. And what we can do instead of saying that silly OB or I really don't like that midwife or whatever, you can have those feelings, but how do we make this better? And I totally also acknowledge that some of this is just individual personalities. But I also think from a system level, we have some stuff that we could work on. All right. I hope you all found that helpful. I would love to know your all's thoughts. Message me on Instagram. Um, and we can keep up with this conversation. Have a wonderful week, everyone. If you're in Canada, it is family day. So my kids are home. We're going to go sledding. We just got knocked with a huge storm. So we're going sledding. We're being outside today. It's beautiful now. But have a wonderful week. If you're looking to get into pelvic live, we have 3 courses coming up in the next couple of months. Rachel is going to be in Windsor, Colorado, March 15th, 16th. I am going to be in Burlington, New Jersey, March 29th and 30th. And then April 15th and 16th, Heather and Rachel are going to be in Bellingham, Washington. All right. Have a great week, everyone. And we will talk to you all soon.